of point counters in glaucoma. In the interest of time, since we are running late, I would request all the speakers to please stick to their time. And at the outset, before starting the session, I would like to thank Team Scientific Committee, AIOS, for giving us this opportunity to organize this program. And as we know that glaucoma is the topic of debate, always we have got several points of debate. So to take that topic further ahead, a step forward, we start this point-to-point counter session in glaucoma. And before that, I would take this opportunity to welcome all my esteemed panelists and the esteemed speakers to welcome everybody. So please, everybody is welcome. And I would like to take again the opportunity to hand over the mic to my co-chairperson, Dr. Shalini ma'am, for taking it further ahead.
Thank you, Dr. Shweta. A very good afternoon to all. And this is a very interesting session, a debate on various topics of glaucoma, in which we all are really confused many a times what to do and what not to do. So we have wonderful speakers today for this debate session, and then we have panelists to give their opinion. Now, so the first talk would be about ocular hypertension to treat or to observe, and for that we have Dr. Ankur Sinha, who is down with COVID, and therefore his recorded presentation will be there, and Dr. Purvi Bhagat. She is a professor at BJ Medical College, Pune. We welcome her here in this session. Ahmedabad, sorry. BJ Medical College, Ahmedabad. Then we have next topic on clear lens extraction for primary angle closure disease. And for that, we have Dr. Shikha Gupta, who is professor at Dr. R.P. Center of AIIMS, New Delhi, and Dr. Shefali Parikh. We know her very well. She is in charge of the South Zone of the Glaucoma Society of India and director at Shriji Eye Clinic and Palak's Glaucoma Center at Mumbai. Then next is neuroprotection, a marriage. Dr. S. Kavita is here, who is heading the glaucoma services at Arvind Eye Hospital, Pondicherry. We welcome you, madam. And then we have Dr. Vinita Gupta, who is a glaucoma expert from AIIMS, Rishikesh. Next, we have another very interesting topic where the question is traditional trabeculectomy still the gold standard, or we are moving towards a sutureless surgery, for which we have Dr. Rakesh Shakya, who is heading glaucoma at Chitrakoot, Sadguru Netra Chikitsalaya. And we have Dr. Rupali, who is at Dinanath Mangeshkar Hospital, Pune. And finally, we have detection of myopia in glaucoma, fields versus OCT, for which we have Dr. Sachin, who is director at Samarth Eye Clinic, Mumbai, and Dr. Talveer Sidhu, who is assistant professor at Government Medical College, Patiala. Finally, we have esteemed panelists, and I would request the panelists to kindly come on the dais. Dr. Subhashini K., who is professor and head at JIPMER, Pondicherry. Dr. Preeti Kamdar. She is already there. She is a glaucoma expert, very renowned glaucoma expert. Dr. Neha Midha is already here. She is director at Avantika Eye Care. And Dr. Dipanjan. Dr. Dipanjan is here.
He's there.
Dr. Dipanjan, please come at the dais. Glaucoma expert at Disha Eye Hospital. And we have Dr. Shiraz Ali, who is a medical superintendent and glaucoma expert from Jharkhand. So now we are moving on to first presentation, which will be on ocular hypertension, whether to treat or not to treat. What we would request that we will be playing both the sides. Dr. Ankur Sinha's presentation can be started from this podium, and we have the other podium for the other expert. AV people, kindly note this. We will be having two presentations simultaneously. So Dr. Ankur Sinha will be speaking from this podium, and Dr. Purvi will be speaking from the other podium. So similarly, you will put all the presentations so that we don't waste the time.
And in the interest of time, just a second, in the interest of time, again, I would request all the speakers to please stick to the time so that we can take more number of questions. Thank you.
So you play the presentation from Dr. Ankur Sinha. We can play from the pen drive only.
In the meanwhile, can we ask Purvi ma'am to start her presentation? Any side, ma'am. Ma'am, you can start from that side.
It is 1:30 presentation, yes. Yes, the top one is Dr. Ankur Sinha.
The office bearers of AIOS, Dr. Shalini and Dr. Shweta, for making me a part of this debate. I am so sorry that I am not able to attend this marvelous DreamCon 2022 because I have recently turned COVID positive. I'll be talking in favor of treatment of ocular hypertensives. Ocular hypertensives are a group of patients who have higher IOP, but discs and fields are absolutely normal. Now, what we know from the past, that is the OHTS. It was the largest randomized clinical trial to establish the efficacy and safety of ocular hypertensive treatment in prevention of onset of open-angle glaucoma in ocular hypertensives. So the study was designed with a screening of more than 3,000 patients, with nearly 800 patients in the observation arm and 800 patients in the medication arm. And the patients who were treated at all point in time, they have lower IOPs as compared to the ones who were observed without treatment. Now, what do we learn from OHTS? At 5 years follow-up, the cumulative probability of developing open-angle glaucoma in ocular hypertensives is nearly half in the treated group as compared to untreated group. We also know that the African Americans are genetically more predisposed to glaucoma. So if we remove that subset of African Americans, the cumulative probability of developing glaucoma is nearly 1/3 that of the people in the untreated group. So this treatment may be of greater benefit, especially in the Indian scenario. Also, we should look at the fact that only the visual fields and optic disc was used in the OHTS, as there was non-availability of RNFL and GCC analysis. Now, this is a case of 47-year-old male with high IOPs, 0.8:1 large cup, high myopia, open angles, and nearly normal pachymetries. And these are the visual fields. So at the one look of these visual fields, we feel that the patient should not be treated. But this is the disc which is showing you a 0.8:1 cupping with a diffuse nerve fiber layer loss. And this is the Heidelberg and the OCT of the patient showing you diffuse nerve fiber layer thinning in both the eyes. Now we look at some deeper facts. There are risk factors like myopia, age above the 40s, strong family history, and higher IOP. We look at his father's history. The father also has a large cupping with thinning of NRR, and again he has no focal defects but diffuse nerve fiber layer damage in both the eyes. And these are the visual fields and OCT of the patient, father of the patient, where we can see that the left eye is pretty significantly damaged. So observation is not a good idea. So this patient was put on treatment and the patient is controlled on treatment. So points to ponder here is OHT is a definite clinical entity. Treatment options should be seriously considered, especially in settings of family history, age, myopia, and Indian scenario in terms of irregular follow-up. Thank you.
Dr. Ankur has actually made my job easier. One, he is not physically present. And second, in the case discussion, he has highlighted many of the points which I'm actually going to relate in my presentation. So I'll be talking on the observation component. So as discussed, when we talk of OHT, it is always the OHTA study which we talk of. But if we see in the details, and as Dr. Ankur has already mentioned, 5 variables were specifically highlighted which are predictive of developing glaucoma. And they were age, increased intraocular pressure, a thin corneal thickness less than 555 microns, a vertical CD ratio more than 0.5, and an increased pattern standard deviation. So these risk factors were identified for development of glaucoma. If we categorize all those patients which were enrolled in that study, they could be graded into low risk, middle risk, and highest risk, less than 6%, 6 to 13, and more than 13%. So if you see the difference which we quote was more significant for the highest risk categories and not for the low and middle risk categories. If we see the number needed to treat, whenever we are in a dilemma as to whether to treat a condition or not, we consider NNT, that is the number needed to treat to prevent the disease. So the number needed to treat to prevent just one case of a primary open-angle glaucoma, it is about 16, 17 in the middle and high-risk groups, but it is as high as 98 in the lowest tertial group. So you need to treat 98 OHDs to prevent just one POAG. So why all this debate? Because whenever we are in a zone of uncertainty and the gray areas, we always want to play safe. And the safest for us is to ensure ourselves that we have done something for the patient, and that is by prescribing a drug for the patient, which may actually not be needed. Second thing is we are always scared of this demon of PAOG. What if the disc develops damage? What if field defects develop? But we now have so many sophisticated tools. We can spend time counseling our patients and spend more chair time with them and explain them the need for frequent monitoring and follow-up. And all the time we are talking of progression, progression, and progression. But what we tend to forget is the effect that treatment will be having on the quality of life of the patient. So that is something which we strongly need to consider. So in an attempt to prevent POAG from developing from OHD, we need to consider the burden of therapy that the patient is going to have. And there needs to be no reference. We all know the burden of therapy, the adverse effects of the drugs, the preservatives, the cost, the inconvenience of therapy, and the compliance issues that are there. And not forgetting the uncertainty of efficacy, when to add, when to substitute, and all those complexities that are there in medical therapy. And now there are risk calculators available free of cost, so you can always feed in your patient's data and see what is the risk of developing glaucoma in that patient, and then you can manage accordingly. So you have to calculate the risk-benefit ratio. What is the risk factor present in that patient? What is the ultimate benefit that is going to be the patient? What is the burden of lifelong treatment? And mainly, what is the risk category of that patient? And then we can decide whether we want to treat or to observe. So definitely not all OHDs need treatment, and there is a very strong reason not to treat indiscriminately. And all we can do for these patients is simply observe with a frequent follow-up and monitoring. Thank you.
Thank you so much, Dr. Purvi, and that was a very nice rebuttal also. So I would request my panelists to pay some important points about whether to treat or not to treat. Dr. Subhashini, would you like to say?
Yeah. So well debated, Dr. Purvi. So actually, we need to consider the number needed to treat. And for the high-risk category, it's around for every patient, at least the number needed to treat, for it would be 7. As compared to the low risk, where you have to treat 98 patients to get to prevent one OHD patient from conversion into the POAG. So, actually we need not look at the OAT study. I don't know how it applies for the Indians, because the average corneal thickness, they found central corneal thickness as the most important and independent and strong risk factor for predicting progression to POAG from OHD. But if you see the Asia-Pacific guidelines, where the average corneal thickness for Indians is around 502 or 510, around that. So does it, do we come under the high-risk category? So that's the question. So how much to give credence to the OAT study, especially in the Indian scenario, it's the, we can't tell. But it's worthwhile treating the high-risk group. Definitely, that is the high-risk group where the cup disc ratio is more than 0.7, and the cornea is really less than, corneal thickness is less than 500. There it's worthwhile treating, so that the person does not go convert into primary open-angle glaucoma. So this is what, these are important points to be pondered over.
Thank you, Dr. Subhashini. So is there any role of the risk calculator? Any would like to comment? Dr. Preeti, would you like to comment?
The OAT study said that even family history was not important. I mean, that's, we have genes developed for diagnosing primary, which we know that are passed down through generations. So, and the risk calculator also does not take that into account. So I would say instead of giving a numerical value to everything, we just, as OAT study has done, like low risk, middle risk and high risk, and so we have patients, we classify them in which category they fall, one. So I don't use any risk calculator, I just put them into these categories and give family history of glaucoma, weightage, what is the mental mindset of the patient. There are some patients when 20 to 23, they sneeze and they come running to you, my pressure has gone up. So if the patient is, his quality of life is going to be disturbed that much and he's going to be reassured that I just need one drop and he's fine, I would rather treat. Explaining to him, after explaining that if you're worried, I'm treating you only because you're worried. So I don't use any risk calculator. I have not found it useful in my practice, and I disagree that diabetes has a protective effect. I don't think there is any, evidence in either ways, whether it is protective or it is not protective. So in one sentence, I don't use a risk calculator when I'm advising any glaucoma patients, or OHT patients, sorry.
Thank you, Preeti ma'am. So the bottom line take I would like to take and share it with my audiences, that if your patient is having the high risk factors, please go ahead, discuss the option with your patient, make a patient party to your treatment regime, and then you go ahead with the treatment protocol, whatever you want to start or you want to observe. Let the patient be the deciding factor along with you. So now may I take this opportunity to start the next debate point, that's clear lens extraction in PACD. For that, I would like to invite first Dr. Shikha Gupta, who is going to talk in the favor that, okay, the lens can be extracted, a clear lens, when it is coming to a primary angle closure disease.
Thank you, ma'am, for inviting me here. Without wasting time, I'd like to go ahead with the presentation. So I'll be talking in favor of clear lens extraction in primary angle closure. Primary angle closure basically indicates that the patient has had high IOP, either in the form of acute angle closure attack or he has intermittent high attacks. So if we compare it with laser peripheral iridotomy, that is the conventional measure for treating these patients, 50% of patients in the PAC group may still progress to PACG at 5 years. Let's see how the biometry looks like in these patients. They have a thick cornea, steep posterior cornea, small anterior chamber depth and volume, convex iris configuration, very shallow and occludable angles, anteriorly placed lens with respect to the ciliary body, high lens vault, and high lens thickness. So these are the parameters that lead to the angle closure attacks. So early phaco IOL is more effective versus LPI in preventing progression to chronic PACG, as well as reducing the burden of medications in these patients. And when we look at in patients, those who have once attack of acute angle closure, up to 71% reduction from presenting IOP may be there, and they may rarely go on to usage of long-term glaucoma medications or a surgery after phaco IOL. So if we compare it with LPI, after LPI, there is no change in visual acuity or in the progression of the visual fields in these patients. Some complications because of PI, like prolapse of vitreous and macular edema, may occur, but the advantage is that accommodation by natural lens is not ameliorated in patients undergoing LPI, unlike a phaco IOL. However, phaco IOL helps in achieving better IOP reduction over long term, because we are taking away the lens, which is partly pathogenic in these patients by having high thickness and anteriorly placed. They achieve better BCVA, fewer anti-glaucoma medications, and less surgical interventions. Also, when we look at gonioscopy in these patients, they allow larger degrees of open angle and less extensive pars formation following phaco in this group. When we look at complications, at 2 years, almost 40% of patients who undergo LPI, they undergo treatment failure, in contrast to only 10% in those patients who undergo phaco IOL. However, at this point, I would like to say that cataract extraction may be technically demanding in this group, as the patients are anxious, they have inflamed eyes. The AC is shallow, they may be poor surgical view, especially after an acute attack. They may have high IOP, small pupils, posterior synechiae, especially if they have had LPI before. They may also have poorly dilating pupil with floppy iris and iris bleed. Topical anesthesia sometimes may be insufficient in these patients, and they may have higher complications. And therefore, it is mandatory that if we are taking these patients for surgery, we should control the IOP nicely, and we should give peribulbar block, and an experienced surgeon should perform these surgeries. Eagle study said when they had enrolled the patients of both primary angle closure as well as primary angle closure glaucoma, and they said that there's 1.18 millimeter more lowering in the group after clear lens extraction. And it showed greater efficacy and more cost effectiveness than LPI. The added advantage of phaco group is that it can also be combined with MIGS in this era. And hence, I would like to summarize that phaco IOL as an adjunct offers long-term IOP control, and it should specially be performed in patients who are not willing for frequent follow-ups and have lost one eye to advanced glaucoma or are allergic to anti-glaucoma medications. Ma'am, please.
Thank you, Dr. Shikha. Now I would request Dr. Shefali ma'am to tell the other side of the story.
Yes, so I'd like to thank at the outset AIOS, Dr. Shweta and Shalini for giving me this opportunity. And I think my dear colleague has already told that LPI is the first line of treatment. Of course, and cataract surgery, to begin with, it has a lot of complications. It is not technically very easy, or it is more technically more demanding and challenging, especially to the beginners. So just to reiterate my point again, I'm going to talk about the role of clear lens extraction against the role of CLE in PACD. So yes, I do agree with my colleague that there are few studies which have shown that there is a beneficial effect of the cataract surgery. However, this effect is short term and these studies are retrospective. And since Eagle study is one of the landmark study which already she has mentioned, and she has mentioned the results also. And since this Eagle study has published and they have propagated the role of clear lens extraction as a first line of treatment in PACG and PAC, where pressure is more than 30 millimeters of mercury, and since then there is a controversy whether the first line of treatment is LPI or the clear lens extraction. So since it is a landmark study, let's do the little critical analysis of this study. Now, one thing, since this change of procedure or this new procedure is for the management of glaucoma, if they are asking for, or if they want to know whether this clear lens extraction is going to change the management of the glaucomas, and we need to ask few questions to ourselves. Is this new procedure, is there any added advantage of percentage IOP reduction that it is causing? Reduction in the number of medication? Is there any change in the angle status? Is it arresting any structural or the functional damage? And is this study identifying any high-risk groups like lens fault and lens thickness? So these are the two groups, clear lens extraction versus the LPI, which is the standard care. So this is one of the results. If you see the axial length, to begin with, these patients that they enrolled in the Eagle study, they are little hypermetropic, 22.5 versus 22.7, and more hypermetropic in the clear lens extraction group. And if you see the refractive error pre and post surgery in the clear lens extraction group, the one from 1.6 refractive pre-surgery to 0.08, that is nearly negligible. So the question that we need to ask is the difference in the refractive error responsible for the improved quality of life. Because one of the results in the study was that, there is improved quality of life in patients with clear lens extraction. So we know that once you treat the hyperopia, patients are much more happy. Second result, on the basis of which they propagated that the clear lens extraction is, they propagated the role of clear lens extraction. The difference was 1.18 millimeters of mercury between the two groups. So this difference even failed to meet the criteria of their hypothesis. If you see the gonioscopy, nearly 60% of the patient did not have gonioscopy at the end of 3 years. So my question on clear lens extraction versus LPI is, does this study provide any extra information on progression of disease? Angle, no additional information, gonioscopy is missing. IOP, only the difference is 1.18 between the two groups. And to achieve this reduction of 1.18, is it in any invasive surgery is advisable, that too in a technically much more demanding eyes? This can feel there is very limited information whether there is an improvement or not, and no information on the lens fault and biometry, which are actually what doing the cataract surgery. We should have those indicators when in which specific group we should do the clear lens extraction. So the current protocol, LPI versus this clear lens extraction, Cochrane review and WGA consensus also states that yes, there is insufficient evidence at this point of time which cases of PACG would get benefit with the cataract surgery. So would I recommend this current practice? Definitely. We need more information of the high-risk groups based on the lens fault, which are likely to benefit from the clear lens extraction. Until then, I'll continue doing LPI as my first choice. Thank you.
So I would thank both the speakers for bringing out their points so beautifully, and I would like to take the expert comment from Dr. Dipanjan Pal, who is having a vast experience in the field of glaucoma. Sir.
Yeah, both these point, counterpoint are fantastically taken, especially Shefali madam would always be like this, fantastic. And for me, if I take out all these studies and all, with our own clinical experience, what we have seen, we are a large volume cataract surgery center, and we have lot of cataract patients who has like primary angle closure disease with cataract patients. So even if we operate or remove cataract in this patient, the disease still progresses. Most of these diseases, and the percentage of eyes who are really going to benefit from only clear lens extraction are supposed to be at, for me, it is around 4 to 5% only. Probably the group of patient who shows Mount Fuji sign on gonioscopy or have lens fault, which is not acceptable, the lens being the most pathological mechanism for the angle closure disease. And so for me, glaucoma and cataract as two different things. The patient who has angle closure glaucoma should be treated as angle closure glaucoma, and clear lens extraction is definitely not the first line of management.
So thank you, Dr. Dipanjan, and I think clear lens extraction is not the answer. But yes, in cases with mild to moderate glaucoma, where there is a cataract already existing, we can have lower threshold for cataract surgery. But once the patient is having advanced glaucoma, obviously we have to deal those patients like primary angle closure glaucoma.
Can
only.
I add a point?
Yeah,
Actually,
sure.
in the Eagle study, the age group of the patients also were higher. The average age was 50 and above, and they had some mild cataract. So that is what appeared to be successful.
The density of the nuclear sclerosis was not mentioned clearly in that
Not
study.
mentioned. Yeah, agreed. Thank you so much, both the speakers. And now I would like to move on to next presentation about a very controversial topic, which is neuroprotection. Is it a marriage? We have Dr. Kavita for and Dr. Vinita against it.
Good afternoon, everyone. Thanks for the opportunity. So, neuroprotection, Amarat. So, as we all know, glaucoma is an optic neuropathy, basically a neurodegenerative disease characterized by loss of retinal ganglion cells. And glaucoma is viewed as a disease of intraocular pressure. So, we always equate glaucoma is equal to intraocular pressure. But we all agree with the fact that intraocular pressure is only one of the risk factors. And recent evidence indicates that lowering intraocular pressure does not prevent progression in all the patients, and we have factors beyond the intraocular pressure. So hence this strategy came of treating the disease by preventing neuronal death. So there are a lot of pathways which leads to the neuronal death, apoptosis, and the loss of retinal ganglion cells. There can be neurotrophin signaling, genetic factors. Ultimately, what we land up is like apoptosis and loss of RGCs. So this is a very big, attractive list. I know my opponent is going to show this. It looks very, very attractive. Big number of medications, oral preparations, topical, everything. But the sad fact is, except for anti-glaucoma medications, everything else is still in the experimental stage. When I was in college, it was an experimental stage. I have completed my PG. Now I have completed 12 years of a consultantship, but still it is in experimental stage. So even if you take anti-glaucoma medications, which is shown in the list, IOP reduction is the only factor by which it offers neuroprotection. So what about the other drugs? We have Pointin. So it was promising in animal studies, but what happened? In randomized human trials, it was proved to be ineffective. So what about other drugs? So we have calcium channel blockers. We have to weigh the risk and the benefits before we prescribe any drug to the patient. So the ischemic stress causes the reduced perfusion to the optic nerve head, and it again compromises the health of the optic nerve. We have drugs like curcumin, which showed positive response in animal studies but could not prove the same in the bioavailability in the human trials. So what about stem cell therapies? Yes, lots are coming up. These studies demonstrated successful differentiation of the human embryonic stem cells into RGCs in the host retina. But in which stage it is. This is still in the experimental stage and nothing has come to clinical practice. Just to conclude, there has been increasing interest in neuroprotective therapies for glaucoma, but definitely it faces several challenges. So whatever trials we don't have head-to-head comparison of the conventional treatment and the neuroprotective therapies to prove, to demonstrate the benefits of neuroprotection. And the sad fact is, IOP lowering using the anti-glaucoma medications is remaining the first line in the management of glaucoma. And there are a lot of ethical and scientific challenges to develop novel drugs for neuroprotection. I know how hard it will be for Dr. Vinita. It is really, really hard. And I think the day is not far. Though it looks like a mirage now, I hope we definitely will land up in a day when not only me, all of you will be standing with Dr. Vinita. So we will have drugs not only to treat glaucoma using neuroprotection, but to prevent glaucoma. Thank you.
Thank you, Dr. Kavita. I know, obviously, you have spoken for that neuroprotection as present. We have not been able to translate it into clinical practice. But as you've already rightly mentioned, that neuroprotection and neurodegeneration is the main culprit which is there in glaucoma, and retinal ganglion cells are dying in front of us. And IOP lowering itself does not protect and prevent this degenerative process, because there's damage which is occurring not only in the pathways of the survival pathways of the retinal ganglion cells, but it also there are various triggers which are happening and which are causing apoptosis to these cells. So as you've already rightly mentioned, that elevated IOP as well as the ischemic damage is there, which is ultimately causing this retinal ganglion cell apoptosis. But neuroprotection is definitely an approach which we have to adapt. Why? Because even if you look at the currently available AGMs or the anti-glaucoma medications which we have, they have some improvement in the ocular blood flow, especially the brimonidine and the prostaglandins and even dorzolamide. They are decreasing resistive index of your posterior ciliary circulation as well as in the ophthalmic artery, and that is having a protective effect to your nerve. So next generation of therapeutics, which we are, the studies which are happening at the stage of clinical trials are going on at different levels in US and in other parts of the world, are what they're targeting is the survival of the RGCs as well as rebuilding the neuroconnections as well as something called as neuron enhancement. As you said, rightly said, there's a list of medications targeting different strategies and different ways they have to work and to work for neuroprotection. And there are multiple clinical trials which have been done and are in the phase 2, phase 3 of clinical trials, especially related to brimonidine, whose role has been, I'll be mentioning about the study which is related to that, which has shown that obviously besides its IOP lowering effect, it has a separate effect on neuroprotection. Similarly, memantine, I would say, obviously I agree, did not translate into the trial results were not positive, but we have the stem cell transplantations and the mesenchymal which have been done for the NAION, and they have shown positive results. And similar trials are going on for the patients with glaucoma. And same is for gene therapies, which have shown positive and good results for patients with LHON, and these similar trials are going on for patients with POGs. So neuroprotection with topical medications, as I already mentioned, for brimonidine, it is well established by various studies, although they are animal studies. But obviously one of the studies, which is the LOGATS studies, which was a randomized double-masked clinical trial done in Singapore, which showed that elevated neuroprotective effect of brimonidine was found to be much more than that of the timolol. It was 9% versus 30% for the timolol, and the assessment outcome measure which we had assessed was the field progression, and this was dramatically less. Field progression was seen with the use of brimonidine as compared to timolol, and this findings were further reiterated by Demoros et al., who found that this neuroprotective effect of brimonidine is unrelated to IOP lowering effect, and neither it is related to changes in the ocular perfusion pressure. So current approaches to neuroprotection which are being targeted now are strategies to improve the optic nerve perfusion, rescuing the damaged retinal ganglion cells and the optic nerve regenerations. And so we have the ROCK inhibitors which are being tried for this in the form of topical applications and intravitreals, the centrally acting calcium channel block inhibitors, and also by use of flunarizine, which tends to increase the aqueous outflow as well as acts as an NMDA antagonist. While neurotrophins are the ones which are being used for rescuing the damaged RGCs by application of various neurotrophic factors by exogenous means, and also strategies are being adopted to inject them intravitreally as well as intracamerally, and transplantation of these to the retina. and genetic engineering studies are going on for reactivation of these receptors. One of these is is the Renex's NT501, which is under trial in US at present, which is injected into the pars plana and stays there throughout life, and has undergone phase 2 trials for other retinal degenerative conditions like retinitis pigmentosa and MACTILs, and has given positive results for that. And currently, it is under trials for primary open glaucomas as well. While for optic nerve regeneration, we have various strategies to block the inhibitory signals, enhance the intrinsic growth, and stem cell transplantations. And which have again, ROCK inhibitors is one of the groups which is being used under trials for this, and the NOGO or the oligonucleotide-derived proteins are being used. And for enhancing the intrinsic growth ability, again, we have the CNTF-based growth factors, which are being given as viral transcription factors. And finally, the stem cell translations for enhancing the survival of the RGCs.
Thank you so much, Dr. Vinita. That was indeed a wonderful presentation, and by both the speakers.
In the end, I just need to conclude that this DART which has come up, that is going to be a useful thing for translating, because what is the problem which is happening with the trials on neuroprotection? They are very long trials, because obviously the disease per se, glaucoma, to give results as clinical translation of the clinical effect, as visual field effects or something to pick up in that, the DART has an advantage on that. So DART is going to be a technology which will help in picking up the apoptosis of the RGCs at an earlier stage.
So let's see that whether our panelists have agreed to it or not. So I will request Dr. Shiraj to throw some light on neuroprotection.
Neuroprotection in glaucoma is no doubt full of promise, but clinically proved strategies have remained elusive. So it should be an active area of research, but one good advantage of neuroprotection in glaucoma is that it targets the common final pathway of neuronal loss at the level of RGC and axonal projections, irrespective of the mechanism of glaucomatous optic nerve head damage. So for me, it's still a mirage.
So for me, in my practice, for all patients of glaucoma, in the terms of neuroprotection, I would like to advise them meditation. I don't know how much all these micronutrients work, but definitely meditation has already shown proven benefits in neurodegenerative diseases like Alzheimer's, and a good body of work has already been done at RP Center, which shows very good effect. So I think it is something non-invasive, patient doesn't have to buy, it doesn't cost. So irrespective of anything, we should advise meditation to all our glaucoma patients. It will be good for overall well-being of them in addition to IOP lowering.
So yes, ma'am.
One is for the comprehensive ophthalmologist, is the best neuroprotection is lowering intraocular pressure. That is one thing. Second is the study which Dr. Vinita mentioned, where brimonidine has a neuroprotective effect, and that is one point which has been sold by the pharma companies to all the comprehensive ophthalmologists. So when a patient, when I asked, why did you not start him on PG analogs? No, brimonidine also has a neuroprotective effect, and that's why I started. That's not the thing. As I said, the first thing is reduce IOP is a best neuroprotection. So don't use these topical medications because of their neuroprotective effect. So this is one point. Yeah, this is just one point I wanted to get across to the comprehensive ophthalmologist.
So I think we are very loud and clear in conveying a message that neuroprotection has role in when it comes to glaucoma treatment, but only after lowering the pressure when nothing is working. Then that is the last resort with you left. Else don't try the neuroprotective drugs topically before starting anything ahead further. So thank you very much, Dr. Vinita. And taking the discussion one step ahead, since Dr. Rakesh Sakya would be joining us late, we are moving on to the last topic, that second last topic, that's detection of glaucoma in myopia. And for that, we are having a discussant as Dr. Sachin Darwarkar and Dr. Talveer Sidhu. So over the first, it's going to be talked by Dr. Sachin.
Okay, thank you so much for having me here. Welcome to all of you in Mumbai. So I'll just be giving a couple of examples to prove the point. So myopic discs are a spectrum. They are not one disc or one picture. So you have tilts, staphylomas, peripapillary atrophies, myopic macular degenerations. So one size does not fit all in either diagnosis or treatment. Well, these are the kind of reports that you get in myopic discs. Sometimes you may be lucky where you can get a good image. Fields you can get in all. So imaging does work in some, but fields work in all, without exclusion. Well, most will not be that lucky. You have these kind of cases where you have post-operative scenarios, tilted discs, and large peripapillary atrophies. You have the scans which are pretty irregular, poor segmentation, poor image qualities. These are the most scans that you see in myopic eyes, and these are not good too good to have and have very less relevant clinical information. Yeah. So structure function dissociation is always very common in myopic eyes because of the contribution of other factors too. So we are looking at functional impairment after all. So anyways, you are not going to treat the structure as such. So ultimate goal is to prevent functional loss, and function is the denominator which you are going to follow. Progression maps prove stability on treatment in such eyes very easily, whereas getting progression, it becomes even more difficult on imaging in myopia because basically getting the scan itself is a big problem. Okay, so always an important pointer for myopic tilts versus glaucoma changes, which you can easily identify on the fields based on the location. Abnormal discs, myopic chorioretinal atrophy and floaters, disc hemorrhages. Everybody is scared on the OCT, but in visual field people say bring it on. Anything and we can do it, we can analyze that. This is what you get in OCT in the same patient where you cannot even visualize the disc and the disc margins. So the difference is pretty clear. Severe constriction of fields, but overview printout shows stable disease in the same patient which I showed you. So there is no problem with visual fields, whatever the scenario, whichever the myopia. Answer is pretty clear. RPE atrophy, intra and subretinal bleeds. What will you depend in these cases? Disc, RNFL, ganglion cell? I don't think you have an answer in OCT at all. So the question is a pretty clear answer. You do the same patient on fields, you have a definitive answer to every situation. So when I would just conclude this by a slight filmy style. देख कर पढ़ा रिपोर्ट पर अल्फा बीटा गामा का छाला, पीपीए स्टैफिलोमा और फ्लोटर ने इमेजिंग का ऑप्शन ही जला डाला। बचपन तो गया, जवानी भी गई, अब तो बस हमें इमेजिंग का ऑप्शन दिला दो। So take home message is disc exam, IOP monitoring and fields are cornerstone of management in most myopic cases. Extreme caution in use of imaging in myopic eyes is mandatory. Thank you so much.
Thank you, Dr. Sachin. Now, on the other side of the story would be Dr. Talvi talking about against the imaging modalities.
That was a wonderful presentation, but I would like to differ from sir in that once you talk about fallacies of visual field testing in glaucoma, it's very important to note that 10 to 17% of myopic patients who are normal, who have normal eyes, non-glaucomatous, can have glaucoma-like visual field defects which will never progress. So it's very important to always realize that these patients who are having visual field defects can be due to the peripapillary atrophy or abnormalities in the optic discs, which will never progress, and they need to be monitored. And quantification of monitoring can only be done by OCTs. Although I also agree with him when he says that there is no choroid, there is no Brooks membrane at the peripapillary atrophy areas, and it is difficult to analyze the RNFL thickness maps at around 3.4 microns, around millimeters around the disc. It's very difficult. Yes, it is difficult. But nowadays, we have started imaging differently. We've started looking at a different perspective. It has been already mentioned in various articles that the macula structure hardly ever changes unless obviously there is pathological myopia and the RP atrophy is going on in the entire macula. The macular structure hardly ever changes in glaucoma, and the en-face imaging that is being done in almost every machine will give you very good information. As you can see here, that in the picture above you can see that around the disc the retinal nerve fiber layer on en-face imaging usually seen as yellow, but in the place where there is an RNFL defect, you will see a blue wedge defect always, and corresponding to that you will be able to find obviously visual field defects. But in such cases also you need to monitor the patients for visual field. progression, especially if they come with intraocular pressures way within normal range, and not just start treating them immediately, especially if they're low-risk patients and they do not have any family history of glaucoma earlier. Also, you will see that when you look at the ganglion cell layer onto the left side of the screen, you will not be able to notice much of the visual RNFL defect. But if you look at the NFAS imaging again, and you can see that there is a superior RNFL defect going right supratemporal from the disc here. Also, the sensitivity and specificity for diagnosing glaucoma using the same imaging and also combining it with OCT angiography. The top picture is a high, healthy myopic eye where there is no RNFL, there is no defect on the NFAS imaging, but below you can see a very nice defect which is present in the inferior part. So OCT gives you a very good information in glaucoma, and it has also been noted that more than 80% sensitivity at 90% specificity is present for ganglion cell thickness for diagnosing and the structural abnormalities that are actually present in glaucoma patients. So not obviously looking just at the quantitative RNFL, but also looking at the N-phase imaging and also looking at what is present over the entire macular map that you're doing in OCT is very important, and that can give you very good information, and also you can check for progression in people and also rule out glaucoma if these people do not progress with time. Thank you so much.
Thank you, Dr. Talveer. Indeed, it was a very nice and elaborated presentation, and just you have shortened it in 3 minutes. I would like to take opinion of Dr. Neha Midha in this particular topic, as she's been a part of an institute which was all loaded with the imaging modalities along with you. So let me see whether she's going to save you or she's going to save Dr. Sachin.
And I would definitely say she has well debated a difficult topic. And my personal opinion on this is that definitely in myopia, the first and foremost is your clinical depiction and what you draw on your paper, rather than relying on any of the modalities, whether visual fields or OCT. Both can be misleading at certain points. But as Dr. Talveer pointed out, that looking at the macula and doing ganglion cell analysis, if the kind of myopia the patient is presenting with permits you to do that, then it's definitely a very good modality. But in certain cases where even the macula is very badly involved, there is nothing much that can be done, and we have to rely on your clinical examination only, or rather I can say serial disc photographs is the key for me.
So can I add a point? Actually, diagnosing glaucoma and myopia itself is a real challenge, even clinically, because the discs are tilted. You can't appreciate the cup margin, and they might be small, they might be large discs, and then they can have this large peripapillary atrophy. And so it's actually, we need to, everything is complementary to each other. We need to check the intraocular pressure, the clinical evaluation, and take both OCT as well as fields. Because in fields, again, you can go for a 10-2, that would be helpful. And in OCT, again, though GCC is comparatively better to RNFL analysis, but in those cases where there's a macular degeneration, the Fuchs fleck, and other changes because of the retinal changes because of high myopia, there OCT will not be useful. So you need to consider all the factors, and even in OCT, the normative database also doesn't have myopic eyes. So there again, so just the red flags, you should not consider them. And in very high myopes, the retina is so stretched that the RNFL fibers are all displaced temporally, and the temporal RNFL, the neuroretinal rim appears thicker, and the RNFL appears thicker as compared to the superior and the inferior. So actually you need to take all together, and then you have to use your clinical judgment rather than relying on one particular modality for diagnosis. But at the end, I would say it would be a real challenge to really decide and treatment. But I think you should have a low threshold for treatment in high myopic eyes, and consider intraocular pressure as an important criteria rather than the other things.
So my 2 points would be, Can I add just?
Yeah, sure.
My 2 points would be the first thing that all myopic discs should be taken as glaucomatous until unless it is excluded otherwise. Dr. Ravi Thomas used to say this, and it has been just glued into our ears, one thing. And another thing is the most ideal thing would be to do serial disc photographs. The serial disc photographs are the key at the RNFL, and now there are so many good machines available. And whatever we have in our hand, like OCT, GCPL, whatever armamentarium, we should use to the fullest to understand whether it is deteriorating, and of course low threshold for treatment, because when the myopic discs or they do progress fast and the pressures get a very steep and they lose vision quite fast, just like ankylosing glaucoma. So we should be very careful.
So I think it has been
parameter is IOP.
It has been very nicely summarized by the speakers and panelists that we should be having a comprehensive examination, detailed examination, and disc examination is actually the key factor. But we cannot forget the importance of visual field. But we have to be very careful while interpreting it, because there can be various scotomas due to peripapillary atrophy. OCT can be a surrogate method to help us in diagnosis, but it cannot be conclusive. So now we are moving to next presentation, and that way Dr. Rupali is lucky enough, because her counterpart, Dr. Shakya, has not turned up. Actually, he got busy in one of video presentation. So she will be talking about sutureless trabeculectomy. And Dr. Shakya was supposed to talk about the traditional. Okay, not a gold standard. Traditional is no.
Yes. So the question was, is traditional trabeculectomy still the gold standard?
Yeah.
So gold standard dictionary meaning is perfect or cannot be improved upon. So in medical terms, so essentially something which is a standard at the current times, which is giving reliable results, and against which all newer techniques are compared, is what gold standard in medical terms means. Our aim is to preserve visual acuity and vision fields as well as quality of life, and try and spare the patients from any additional anti-glaucoma medication and their side effects. So that is what your surgery should be giving them. So the technique should be standard, reproducible, have a good success rate, and should flatten the diurnal curve, low complications, and minimal or no follow-up interventions. Should be inexpensive so that it is applicable to a larger population. So let's look at these standards in trabeculectomy. What is standard about it? Starting from conjunctival flaps to how you open it, whether you augment it or not, how you make the scleral flap, what shape it is, what size you make the ostium, whether you use a punch or not, nothing is standard. And all of us, me included, feel that whatever way I am doing it is the correct way, but nobody has any one standard technique. So there's nothing standard about it. The postoperative follow-ups are huge, and 80% of the work in trabeculectomy is to achieve a good result is in the postoperative care, with large number of complications that are likely to happen, and it's a ticking time bomb. We are waiting. Is the chamber going to shallow? Is it going to overfilter? Is there going to be a leak? Will it have choroidals? Then will the hypotony cause vision loss? There's so many things. And it doesn't end there. It's six weeks you think, okay, I'm through now, and then you have to keep following them up, because blebs might sweat, they might leak, they might get endophthalmitis, they might underfilter, there might be multiple. And after all this, if you look at the success rates, most of the studies show that at the end of 5 years, 50% of them are not functioning, you're back to giving them medication. So really if this is the standard we are going to reach up to, this is really worrisome then. If you look at the comparison of the various surgeries that are now available, you'll find that the only thing that trabeculectomy has going for it is, one is that it is not requiring many investments, and secondly, because this has been there for such a long time, we know what to expect from it, while all the others are not here for a long time, so the long-term efficacy has not been proven. But if you just take safety as a factor, and if you look at the efficacy along with it, and the fact that most of the surgeries anyways need post-op medication at 5 years, then you might find that a lot of these newer procedures are much safer in as compared to trabeculectomy. So if you ask me, there is nothing gold or standard about trabeculectomy. It is just that it is a known devil and we are all used to it. It is inexpensive and most of us can safely do it in our practices. That is why, because we haven't found something to fit the ideal new all criteria, that is why we do not have a new gold standard, and therefore we still think that trabeculectomy is the gold standard, but it is neither gold nor standard. Thank you.
Thank you, Rupali ma'am. And I would like to take the expert opinion from Dr. Deepanjan sir. What is his take, that whether, what does he want to convey to the audience?
Yeah. Yes, Rupali was excellent, because it is definitely, it's a difficult against the motion. But one thing is for sure, that we cannot compromise on efficacy as thinking a procedure to be safe. If the procedure is just based on safety, we cannot compromise on efficacy. So we have to look to those days where the other procedures will compare to trabeculectomy with mitomycin C. It will be as efficacious, because trabeculectomy as mitomycin C has shown us that the intraocular pressures are going to be controlled over years, like more than 10 years. It's the longest study has already come. So, and we have enough ideas in our brain to understand that it can be safely done without much problem. And newer, safer methods are coming. And if we feel that mitomycin C is not good enough, we can shift to Ologen also. But Ologen is not, again, I think in long term, Ologen might not be as effective as it is not in supply at all right now, but it has given some idea that it is probably is a good adjunctive when it is compared to. Then again, we are coming to the same point that we are compromising on efficacy, and we are thinking on safety profile. So that is my take.
Yeah. Also, that if you look at everybody says qualified success, but if you look at all the long-term studies,
yes,
they always use 21 millimeters of mercury as their success rate.
Yeah.
I mean, who would do a trab if you needed to get your pressure to 21? It is like we want our pressures to be 12 and 14.
12 and
then
14,
if you look at it, it is not really that great a procedure.
Yeah.
So thank you. It was a very nice discussion. So at the end of this particular debate topic, I would like to convey to the audience that yes, trabeculectomy, definitely it is the initial procedure. It should be initial procedure, and the indications are different from trabeculectomy and MIGS or any other conventional procedure, any procedure you want to do. It entirely depends on the condition of your patient, the status of the ONH, the pressures and everything. If higher pressure reduction is required, trabeculectomy is definitely going to be a treatment of choice. And if you want to go for moderate glaucomas, then probably MIGS or any laser can help you out in that. So at the end, now we like to conclude this session since we are running again late and short of time, and already ma'am is there, Dr. Vanita ma'am is there for the next session. So handing over the dais and the mic to Vanita ma'am, and thank you all for listening to us.